All right, so thank you very much, Mary. All right, so today I'll be speaking about, what is that? Oh, clicker, awesome, okay. So I'll be speaking about actually two different studies that I think are quite relevant to actually many of the studies that have been talked about this weekend. One reason being that facial emotion recognition and actually the processing of facial emotions is often used as stimuli, these faces, in neuroimaging studies to examine emotion regulation, emotion processing, and BPD. And we often assume that, not always, that individuals with BPD are actually processing emotional information, especially socially relevant information, in the way that we expect them to, that they're perceiving negative, neutral, positive faces in a way that healthy individuals do. And that may not necessarily be the case. So I'm going to be presenting the findings from two studies, and it's a little ambitious, but I will be done on time, I promise. The first being a meta-analysis of, this is something done by my graduate student, Alex Daros, whose program of research is actually looking at emotion perception and kind of possible biases in emotion perception in BPD and other forms of psychopathology. And so this is actually the run-up to his master's thesis, this meta-analysis. And then we conducted a prospective study looking at emotional acuity or emotional sensitivity in BPD and how that might relate to this model of emotion recognition that Alex developed. Okay, so very briefly, we all know that cognition, emotion, and social functions are all very important when it comes to perceiving and accurately perceiving emotions in faces. It takes a lot to be able to actually recognize that this face appears happy. And it's therefore not surprising that many people have been interested in studying borderline personality disorder in relation to emotion recognition because many of the core symptom dimensions that are often problematic in this disorder revolve around cognition, emotion, and social relationships. And so given that, these problems may contribute to deficits in social cognition, or it could go in the other direction, social cognition, or both directions. Social cognition, so problems with the ability to understand another person's emotions may contribute to the interpersonal problems that we see on a daily basis in individuals with this disorder. So several studies have been done in this area, and they have found that there are difficulties in BPD when it comes to recognizing emotions in faces. And there's, as you might imagine, a lot of variability across studies. The main problem is that there's low statistical power due to there being usually relatively few participants in these studies. When we talk about variability, much of it is also attributed to the actual emotion recognition task that's employed. Demographic characteristics. Most of these studies tend to be primarily female participants, but we also see a more equal balance across the genders. And diagnostic comorbidity, when reported, is not always examined as potentially moderating the findings of these studies. And so the theory out there, presented by Lynch and colleagues in 2006, basically looked at this idea of hyperarousal, so this physiological arousal potentially contributing to these biases in emotion perception in BPD. Now, what they said was that if we assume that individuals with BPD do have this hyperarousal, this physiological arousal, then at lower levels of expressiveness or intensity, as you'll usually be calling it in faces, they may actually be better able to detect emotions in faces. And so this could be one reason, so hyperarousal might be the reason that we tend to see better recognition, at least in one study, of emotions at low levels of expressivity or intensity. Now, what people have been most interested in is the finding, which again hasn't been 100% consistent, that perhaps these individuals have difficulties recognizing emotions at full intensity, 100% expressivity, and that this may be due to this hyperarousal. Okay, so high levels of intensity, we may see worse recognition in individuals with BPD. And so why this might be hasn't really been clearly articulated, but Alex, in the recent publication of these findings, suggested that If we look at the vertical axis here, we're talking about accuracy going from chance to perfect accuracy, and intensity going from low to high intensity of an emotional expression, that healthy individuals do have difficulty disambiguating low levels of intensity of emotions in faces, and that they get better and better and better as you start to see that face a little more clearly in terms of its emotional expression. However, the thinking, this potential model, is that perhaps at lower levels of intensity, individuals with BPD may actually have higher levels of accuracy. And then as we move on to the more extreme emotional expression in the face, and again, this isn't very well articulated in the literature, but what we suggest is perhaps there is hyperarousal and that this somehow interferes with cognition, and that this might, for example, lead to reduced attentional resources. And again, there needs to be studies actually to confirm this, but this is our thinking. Maybe we're interfering with attention in some way. So going from this, Alex conducted this meta-analysis that I'll go through relatively quickly. We found 11 studies of emotion recognition in BPD, and we addressed the following questions. So the first one is, are there actually deficits or difficulties recognizing emotions in BPD? If there are, which I'll say there are, then what specific emotions do they have difficulty recognizing, or is it a more generalized difficulty across multiple emotions? And then we want to explore whether these deficits might be related to some other things. One possibility is perhaps that they're just less accurate because they're responding quicker and therefore aren't processing these faces as much as they should before they respond. Okay, so like I said, 11 studies. Go through this fast. And the main measure of effect size was Cohen's D, which, as a quick refresher for people, 0.2 is small, 0.5 is medium, 0.8 is large. For those who aren't familiar with this, this is a standardized metric of how strong the difference might be between two groups. And we use CMA to carry out these analyses. And as a sample emotion recognition task, this is something called the Penn Emotion Recognition Task, or the ER40. So typically what these tasks do is present a face on the screen. It's presenting some emotion or no emotion, which would be neutral. And the individual is asked to select among these various options which emotion they recognize in the face. So going from happy, fear, sad, anger, disgust, down to neutral, where we again would say there's no emotion. All right, so when we talk about this sample, well, this combined sample of participants in the meta-analysis, we can say there were 266 patients with BPD, primarily female, about 30 years of age, 255 healthy controls that were matched on age and gender. When we talk about what these people look like, we're talking about most of them being medicated, almost a third being depressed at the time of testing, and I'll talk about why this is important in a moment, but more than a third were comorbid for avoidant personality disorder. Okay, so overall, when we collapse across all emotions, what we found is that there is this generalized difficulty in recognizing emotions. The effect size is 0.45, so we're talking about a medium effect size. Okay, so it's something that is quite meaningful, and it's statistically significant. But what's more interesting are the results by emotion. And so there were the number of studies for each emotion that contributed to each of these emotion categories varied from study to so some studies actually included these, some did not. So that is why we see some pretty large effect sizes but not statistical significance because there's still too much variability. It's not so clear just yet what's going on. But we can say in terms of statistically significant differences between individuals with BPD and healthy individuals that they had greater difficulty recognizing disgust, and this is close to 0.5, so it's a medium effect size, and anger. And these may not be surprising for people given that these are the two most BPD relevant emotion categories here. And this might be consistent with this notion that at full emotional intensity, which is what we're talking about here, all of these are presented at full emotional intensity, maybe those that are most threatening, disgust may be a signal of rejection, for example, in BPD. These may actually be more hyperarousing and result in some type of depletion of cognitive resources and perhaps then result in poor recognition. And we do see, small to medium effects in these other emotions, but where things were most surprising is not in surprise, but in neutral, where we have an effect size that's quite large, almost as, in the 0.8 range. So it was a very strong effect, and it's consistent with, for example, one of the first families that we had in my study at the University of Toronto, where we're doing this large family study of BPD, is I had a mother of a young woman with BPD who pulled me aside when they came in to participate in my research and said, it was really kind of surprising, I really hope that one of the aspects of cognition that you'll be testing is emotion recognition, because for me and my husband, our daughter looks at us, she thinks that we're angry at her all the time, even though we're not. We have a neutral, she actually uses the word neutral, face, but she always thinks we're angry or disappointed in her, and we tell her we're not. Where do you see this? And she kind of is perceiving these emotions. So I think this does have some translation to real world functioning. Okay, and then we did look at this idea, well, maybe they're responding too quickly and therefore not processing the faces as quickly as they should. And what we found is that that's not the case. If anything, they're slower, but not statistically so. And interestingly, age, medication, current depression, and avoidant personality disorder were not related to these effect sizes in any way. It was very, very limited relationships, and the one that we thought might be relevant, avoidant personality disorder, where you see greater, perhaps, sensitivity to rejection, we don't see any relationship of the proportion of individuals who are comorbid for avoidant personality disorder and the effect size measures. Okay, so if we return back to this model of hyperarousal, possibly resulting in attentional distraction maybe, and causing recognition difficulties in individuals with BPD for these high arousing emotions, one thing that hasn't been really clearly really examined in the literature is these lower levels of intensity. What might be going on here? And this is where we talk about Alex's master's thesis, which looked at emotional acuity, this better recognition. Do we tend to see that at lower levels of intensity? So we used, before we talk about what we wanted to do was examine whether emotion recognition accuracy, is it better at lower levels of intensity of emotional expressions for people with BPD? Something that wasn't examined in the previous literature, despite the fact that neutral faces are the most difficult to recognize, is, well, what are they saying on these neutral trials? There's one study that suggests they might be seeing more negative emotions as compared to healthy individuals, but that wasn't clear. So that's something we wanted to examine here. And also we wanted to examine, well, how do depressive symptoms, as one symptom dimension, how do these actually contribute, or do they contribute to this difficulty in recognizing emotions? And we might think that there would be a contribution of state mood, because we know that people who are currently depressed or manic, that they tend to have mood congruent biases. So if you're currently depressed, you might be more likely to interpret a neutral face, for example, as more negative, and if you're manic, you might be more likely to interpret a neutral face as more positive. Okay, so the task we used is known as the Penn Emotional Acuity Test, or the PEAT. It presents a face on the screen, and the participant is asked to rate the face. And so one of the limitations of this task is that we're really going from sad to happy. We're not looking at some of the BPD relevant traits, unfortunately. It's basically a bipolar scale where the middle point of the scale is neutral. And so most people would perceive this as being happy, and then the question is, how happy is it? Okay, so this would be, I believe, very happy. Okay, so moving on from there, we recruited 33 outpatients with BPD from psychiatric clinics in Toronto, as well as online postings. 94% were female with a mean age of 30, and 55% were currently depressed, high BDI score, not surprisingly. We had a very tightly matched group of healthy controls who were matched for age, gender, education, and IQ, which is not always something that is done in this literature. And these were all, again, as I said, about this family study that we're running, recruited as part of a larger neurocognitive family study of BPD. How the family members do, I'll have to talk about in a few years when we've got enough people tested. Okay, so all participants provided a negative urine toxicology screen. As a clinical neuropsychologist, I thought it was important to make sure these people were also trying on our testing, because that's something that we found some people were not doing. So we used something called the Victoria Symptom Validity Test to determine whether their performances on neuropsychological testing, including emotion recognition, were valid, and we had to exclude about 5 people that are not included in these 33 because they simply weren't trying, or at least not trying hard enough. And again, we administered the Penn Emotional Acuity Test as part of this battery. We also know that the groups didn't differ in their basic facial recognition capacity using a test called the Benton Facial Recognition Test. And I should say that nobody who had any history of psychosis, nobody with bipolar I disorder, or any current substance use disorder, abuse or dependence, alcohol or otherwise, were excluded from this study. Okay, so the results. Now, if we look at the extreme ends, which is where the meta-analysis would say we might see the greatest difference, if we look at happy and sad, we actually don't see any differences at all. And this actually was not surprising to me, because these are the easier emotions to recognize at the extremes. This may not be the case if we were talking about disgust and anger, and that's something that we're testing now in our research. Where we did see differences were, first of all, at neutral faces. The BPD group had greater difficulties recognizing neutral faces. They also had greater difficulties recognizing mildly happy facial expressions. And this is something that is more difficult to disambiguate, to actually tell whether something is mildly happy. That's not really surprising. And so, we don't necessarily see support for our model of emotional hyperarousal and how that might actually influence emotion recognition accuracy when it comes to lower levels of intensity. Again, I think it might be because we're talking about specific emotions being more difficult to recognize than others, and that this is what we're testing now. Different levels of intensity go between neutral and full expressivity. Okay, so we see some very minimal results here. One thing that we were very curious to see was, well, what is going on in these neutral trials? On these trials where they should be saying neutral and they're not, what are they doing? Well, what they were doing is they were more likely to select a negative, which would be sad emotion, rather than a positive emotion. And this is suggestive of what people have talked about in the literature of a negative attribution bias to stimuli that are perceived by healthy individuals as conveying no emotion. And so I don't know if this rings true for people in the room here who have worked with these individuals, but I would sense that it probably does. When it comes to looking at other symptom dimensions that might be relevant to this, we did conduct regression analyses to look at how does depression contribute to these poor recognition performances. And what we found is that if you do consider, the long story short, is if you consider depression and diagnostic status jointly, neither one of these is actually robustly associated, not significantly at least, associated with emotion recognition, so that they both actually share a great deal of variance. And so we don't have a clear answer to this question of, is this all just depression that's causing this bias in their emotion perception? But I do have a little bit more to say here in my conclusion slide about that, which is that overall, if I had to give you, take-home messages here of when we combine the meta-analysis and this prospective study, is that individuals with BPD do tend to have significant difficulties identifying emotions in faces. Again, it tends to be with neutral, and that angry and disgusted may be some very specific emotions they have difficulty recognizing at full emotional intensity. And there's accumulating evidence, based on my study and one other one, that there may be a negative attribution bias when they make mistakes in recognizing neutral faces. I think we'd prefer if they were going in the happy direction, but unfortunately they're going in the negative direction. And that this poor emotion recognition in BPD may be influenced by mood state, i.e. depression, although not entirely. And the reason I think it's important to consider this is because, this may be specific to BPD, but we don't know enough just yet. I think that difficulty recognizing neutral facial expressions is not, especially the severity that we see in this group, is not typical of patients with major depression who are currently depressed. and who have no personality disorder, which could suggest that these people have a unique facial emotion recognition profile. And I should say, because we're still analyzing these data, that there's evidence that on the mildly happy trials, where these mildly happy faces are being, they're having difficulty recognizing them, you'd expect if it was all depression that they would be having a negative, bias. Instead, we have preliminary evidence suggesting that they actually have a bias going toward more extreme happy faces. So it's not consistent with what you might expect if this was really all mood congruent biases in depression. And so I'll wrap up by thanking my graduate student who did all the work here, and the BPD clinic at CAMH in Toronto who assisted with the recruitment for this study, and funding from the Canadian Institutes of Health Research and the American Foundation for Suicide Prevention. And I should say that the future work is examining disgust and anger at lower levels of intensity, and also trying to piece together what are the traits and symptoms that might be driving this effect. And that's all.